Good morning, everyone, and welcome to the clinical pharmacology class. The topic of today's lecture is adrenoceptor antagonist drugs, and adrenoceptor antagonists are divided to alpha and beta antagonists, and non-selective alpha antagonists are used in the treatment of chromocytoma and Uh, that is actually a tumor that secretes catecholamines like norepinephrine and epinephrine. And alpha-1 selective antagonists are used in the treatment of hypertension and benign prostatic hyperplasia. And beta receptor antagonist drugs are used in a variety of conditions and that include but not limited to treatment of hypertension, ischemic heart disease, arrhythmias, endocrinologic and neurologic disorders, glaucoma, and many other conditions. So this group of the drugs is the most useful group for the clinical application. Alpha receptor antagonists may be reversible or irreversible in their interaction with those receptors. Reversible antagonists dissociate from receptors, and the block can be summoned with sufficiently high concentrations of agonists. Irreversible drugs do not dissociate and cannot be summoned. Phentolamine and Prastazine are the uh, examples of reversible antagonists. These drugs are um, uh, used primarily for the antihypertensive effects and also uh, uh, also reversible alpha adrenoreceptor antagonist or partial agonist. Phenoxybenzamine is an agent related to the nitrogen mustards, and it forms a uh, reactive ethylene ammonium intermediate that covalently binds uh, to the alpha receptors, resulting in irreversible blockade. Um, and uh, so the effects of uh, the duration of action of reversible antagonists is largely dependent on the half-life of the drug in the body and the rate at which it dissociates from its receptor. The shorter the half-life of the drug in the body, the less time it takes for the effects of the drug to dissipate. In contrast, the effects of the irreversible antagonist may persist long after the drug has been cleared from the plasma. In the case of phenoxybenzamine, the restoration of tissue responsiveness after extensive alpha receptor blockade is dependent on synthesis of new receptors, which may take several days. The rate of return of alpha-1 receptor responsiveness may be particularly important in patients having a sudden cardiovascular event or who become candidates for urgent surgery. Because uh, arterial and venous tone are determined to a large extent by alpha receptors on vascular smooth muscle. Alpha receptor antagonist drugs cause a lowering of peripheral vascular resistance and blood pressure. So those are presented on this picture. These drugs can prevent the pressor effect of usual doses of alpha agonists. Uh, in the case of the agonist with both alpha and beta 2 effects, for example, epinephrine, selective alpha receptor antagonists may convert a pressor to a depressor response. This change in response is called epinephrine reversal. It illustrates how the activation of both alpha and beta receptors in the vasculature may lead to opposite responses. So the first diagram is phenterlamine alone, and uh, that has almost no effect. So and the second graph is epinephrine before phenterlamine. So and that leads to the increase of the uh, heart rate and also a very prompt increase in the blood pressure. And the third diagram is epinephrine after phenterlamine, and that and that we see that the same epinephrine will now decrease the heart rate, uh, increase the heart rate and decrease the blood pressure. So these are the effects of the uh, phenterlamine on the epinephrine action. So alpha receptor antagonists often cause orthostatic hypotension and reflex tachycardia, and non-selective blockers usually cause significant tachycardia if blood pressure is lowered below normal. Orthostatic hypotension is due to antagonism of sympathetic nervous system stimulation of alpha-1 receptors in vascular smooth muscle. Contraction of veins is an important component of the normal capacity to maintain blood pressure in the upright position since it decreases venous pooling in the periphery. Constriction of arterioles in the legs also contributes to the normal orthostatic response. Tachycardia may be more marked with agents that block alpha presynaptic receptors in the heart, since the augmented release of norepinephrine will further stimulate beta receptors in the heart. Blockade of alpha receptors in other tissues elicits miosis, small pupils, and nasal stiffness. Alpha receptors are expressed in the base of the bladder and the prostate, and the blockade decreases resistance to the flow of urine. Alpha blockers, therefore, are used for the treatment of uh, uh, urinary retention due to prostatic hyperplasia, uh, and individuals' agents may have other important effects in addition to alpha receptor antagonists. Phenoxybenzamine binds covalently to alpha receptors, causing irreversible blockade of long duration, up to 2 days. It is somewhat selective for alpha-1 receptors, but less so than prazosin. Uh, so this is a phenoxybenzamine, so it's irreversible and antagonist, uh, covalently uh, linked to the receptor. The drug also inhibits reuptake of released norepinephrine by presynaptic adrenergic nerve terminals and blocks histamine, acetylcholine, and serotonin receptors as well as alpha receptors. The pharmacologic actions of phenoxybenzamine are primarily related to antagonism of alpha receptor mediated events. The most significant effect is attenuation of catecholamine-induced vasoconstriction, while phenoxybenzamine causes relatively little fall in blood pressure in normal supine individuals. It reduces blood pressure when sympathetic tone is high, for example, as a result of upright posture or because of reduced blood volume. Cardiac output may be increased because of reflex effects and because of some blockade of presynaptic alpha-2 receptors in cardiac sympathetic nerves. Phenoxybenzamine is absorbed after oral administration, although bioavailability is low and its kinetic properties are not well known. The drug is usually given orally, starting with dosages of 10 mg per day and progressively increasing the dose until the desired effect is achieved. A dosage of less than 100 mg per day is usually sufficient to achieve adequate alpha receptor blockade. The major use of phenoxybenzamine is in the treatment of pheochromocytoma. Most adverse effects of phenoxybenzamine derive from its alpha receptor blocking action. The most important are orthostatic hypotension and tachycardia. Nasal stiffness and inhibition of ejaculation also occur. Since phenoxybenzamine enters the central nervous system, it may cause less specific effects including fatigue, sedation, and nausea. Because phenoxybenzamine is an alkylating agent, it may have other side effects that have not yet been characterized.
Sir, can I have a question?
Sure.
Do we need to know all these reactions, or we just take a look on it?
All these what?
All this reaction, do we need to know it, learn it by the heart, or just to take a look on it?
All of the selection?
Reaction, sir.
Reaction? What do you
Yeah,
mean by reaction?
this is reactions, chemical reactions. We need to learn it by the heart.
The action like on the body?
No, this is the reactions.
Reactions?
Yeah, the
Formulas?
chemical reactions. Yes.
Yes, you have to learn by heart the formulas. This reaction is the only one. Like usually there is no reaction.
Uh-huh.
because most of the drugs like
Yeah,
they don't
I
react.
know. I
But
know for that.
this is like an exception for the reaction, and this
Uh-huh.
is actually just a schematic reaction. So yes, you have to learn it by heart too, but
Mm-hmm.
there will be only one reaction. Usually we only have the formulas. Like
Okay.
you have to learn the formula for the phentolamine as well as for the prazosin, tamsulosin, actually very important. So uh,
Okay.
not for the old drugs, but for those most important drugs that are clinically useful, you have also learned the formula by heart, and you will learn it at the pharmaceutical chemistry. Uh,
Yes.
so that is why. If you learn it now, then you will save time later.
Okay, sir.
Uh,
Thank you.
so you are very welcome. So the next one is phentolamine. So you can learn it now actually while we're discussing uh, the phenoxybenzamine. So first was phenoxybenzamine. So it's like non-competitive, and phentolamine is competitive, and it's competitive against the alpha 1 and alpha 2 receptors, and phentolamine reduces peripheral resistance through blockade of alpha 1. So yeah, phentolamine here, alpha 1 and alpha 2. Uh, so the peripheral resistance is blockaded by alpha 1 receptors and possibly alpha 2 receptors on the vascular smooth muscle. Its cardiac stimulation is due to antagonism of presynaptic alpha 2 receptors that leads to enhanced release of norepinephrine from sympathetic nerves and sympathetic activation from baroreflex mechanisms. Phentolamine also has minor inhibitory effects at serotonin receptors and agonist effects at muscarinic H1 and H2 histamine receptors. Phentelamine's principal adverse effects are related to cardiac stimulation, which may cause severe tachycardia, arrhythmias, and myocardial ischemia. Uh, Phentolamine has been used in the treatment of chromocytoma. In addition to it is sometimes used to reverse local anesthesia in soft tissue sites. Local anesthetics are often given with vasoconstrictors that slow their removal. Local phentolamine permits a reversal at the end of the procedure. Unfortunately, oral and intravenous formulations of phentolamine are no longer available. So, because actually the drug is very old. Prazosin is a piperazine uh, quinazoline effective in the management of hypertensive uh, diseases. So the prazosin. Uh, it is highly selective for alpha 1 receptors and typically thousandfold less potent at alpha receptors. So alpha receptors uh, are much alpha 1 receptors, sorry, alpha 2 receptors are much less, thousand times less stimulated, blocked by the prazosin than alpha 1 receptors. This may partially explain the relative absence of tachycardia seen with the prazosin compared with that of phentolamine and phenoxybenzamine. Prazosin relaxes both arterial and venous vascular smooth muscles, as well as smooth muscle in the prostate due to blockade of alpha 1 receptors. Prazosin is extensively metabolized in humans because of metabolic degradation by the liver. Only about 50% of the drug is available after oral administration. Half-life is normally about 3 hours. Terazazine is so there is one terazazine here, but terazazine is similar to the prazosin, and it is another reversible alpha-1 selective antagonist that is effective in hypertension. It is also approved for the use in men with urinary symptoms due to benign prostatic hyperplasia. Atrazine has high bioavailability but is extensively metabolized in the liver, same as prazosin, and only small fraction of an unchanged drug excreted in the urine. The half-life is about 12 hours, so slightly higher than slightly higher than the prazosin. Doxazazine uh, is efficacious in the treatment of hypertension and benign prostatic hyperplasia. It differs from prazosin and terazazine in having a longer half-life of about 22 hours. It has moderate bioavailability and is extensively metabolized, with very little parent drug excreted in urine or feces. Doxazazine has active metabolites, although their contribution to the drug's effect is probably small. Tamsulosin is the most uh, useful drug. It, it is a competitive alpha-1 antagonist with a structure quite different from the other alpha-1 receptor antagonists. It has high bioavailability and half-life of 15 hours. It is metabolized extensively in the liver. Tamsulosin has high affinity for alpha-1A and alpha-1B receptors than for alpha-1B subtype. Evidence suggests that tamsulosin has relatively greater potency in inhibiting contraction in prostate smooth muscle versus vascular smooth muscle compared with the other alpha-1 selective antagonists. The drug's efficacy in benign prostatic hyperplasia suggests that the alpha-1A subtype may be the most important alpha subtype mediating prostate smooth muscle contraction. Therefore, compared with other antagonists, tamsulosin has less effect on standing blood pressure in patients. Nevertheless, caution is appropriate in using any alpha antagonist in patients with diminished sympathetic nervous system function. Patients receiving oral tamsulosin and undergoing cataract surgery are at high risk of intraoperative floppy iris syndrome, characterized by the uh, billowing of a flaccid iris, uh, propensity for iris prolapse, and progressive intraoperative pupillary constriction. These effects increase the risk of cataract surgery, and complications are more likely in the ensuing 14 days if patients are taking these agents. The next drug is alfuzazine. Alfuzazine is alpha-1 selective quinazoline derivative that is approved for use in benign prostatic hyperplasia. It has a bioavailability of about 60%, is extensively metabolized, and has an elimination half-life of about 5 hours. It may increase risk of the QT prolongation in susceptible individuals, so that is arrhythmias. Silodazine resembles tamsulosin in blocking the alpha-1A receptor and is used in treatment of benign prostatic hyperplasia and indoramine is another alpha-1 selective antagonist that also has efficacy as an antihypertensive. Uradipil is an alpha-1 antagonist that also has weak alpha-2 agonist and 5-hydroxytryptamine 1A agonist action and weak antagonistic action at beta-1 receptors. It's used as an antihypertensive agent and also for the benign prostatic hyperplasia. Labetalol is both alpha-1 selective and beta antagonistic uh, effects. It is discussed later. Neuroleptic drugs such as chlorpromazine and haloperidol are potent dopamine receptor antagonists but are also antagonists for alpha receptors. The antagonism of alpha receptors probably contributes to some of the adverse effects, particularly hypotension. Similarly, the antidepressant trazodone has the capacity to block alpha-1 receptors. Ergot derivatives, for example ergotamine and dihydroergotamine, cause reversible alpha receptor blockade, probably via a partial agonist action. Yohimbine is indole alkaloid is an alpha-2 selective antagonist. It is sometimes used in the treatment of orthostatic hypotension because it promotes norepinephrine release through blockade of alpha-2 receptors in both the central nervous system and the periphery. This increases central sympathetic activation and also promotes increased norepinephrine release in the periphery. It was once widely used to treat male erectile dysfunction, but has been suppressed by phosphodiesterase 5 inhibitions like sildenafil. Yohimbine, so that is actually Viagra. Yohimbine can greatly elevate blood pressure if administered to patients receiving norepinephrine transport blocking drug, and yohimbine reverses the antihypertensive effects of alpha-2 adrenoceptor agonists such as clonidine. It is used in veterinary medicine to reverse anesthesia produced by xylazine, and alpha-2 agonists used to calm animals. Uh, Yohimbine actually available as a nutritional supplement. Uh, so the diseases that are treated with the alpha uh, receptor blockers include the pheochromocytoma. Pheochromocytoma is a tumor of the adrenal medulla or sympathetic ganglion cells. The tumor secretes catecholamines, especially norepinephrine and epinephrine. The patient in the case uh, uh, has a left adrenal pheochromocytoma that was identified by imaging. In addition, the patient had elevated plasma and urinary norepinephrine, epinephrine, and the metabolites nor, uh, normetanephrine and metanephrine. The diagnosis of pheochromocytoma is confirmed on the basis of elevated plasma or urinary levels of catecholamines, uh, metanephrine and normetanephrine. Once diagnosed biochemically, techniques to localize a pheochromocytoma include computed tomography and magnetic resonance imaging scans, and scanning with radiomarkers such as iodine metal, the radioactive iodine metal iodobenzylguanidine, that is iodine 131 radioactive, a norepinephrine transporter substrate that is taken up by tumor cells. The major clinical use of phenoxybenzamine is in the management of chromocytoma. Patients have many symptoms and signs of catecholamine excess, including intermittent or sustained hypertension, headaches, palpitations, and increased sweating. Release of stored catecholamines from pheochromocytomas may occur in response to physical pressure, chemical stimulation, or spontaneously. When it occurs during operative manipulation of pheochromocytoma, the resulting hypertension may be controlled with alpha receptor blockade or nitroprusside. Nitroprusside is preferred because its effects can be more rapidly titrated and it has a shorter duration of action. Alpha receptor antagonists are most useful in the preoperative management of patients with pheochromocytoma and um, administration of phenoxybenzamine in the preoperative period uh, helps to uh, helps to control hypertension and tends to reverse chronic changes resulting from excessive catecholamine secretion such as plasma volume contraction. Furthermore, the patient's operative course may be simplified. Oral doses of 10 mg per day can be increased at intervals of several days until hypertension is controlled. Some physicians give phenoxybenzamine to patients with pheochromocytoma for 1 to 3 weeks before surgery. Other surgeons prefer to operate on patients in the absence of treatment with phenoxybenzamine, counting on modern anesthetic techniques to control blood pressure and heart rate during surgery. Phenoxybenzamine can be very useful in the chronic treatment of inoperable or metastatic pheochromocytoma. Although there is less experience with alternative drugs, hypertension in patients with pheochromocytoma may also respond to reversible alpha-1 selective antagonists or to conventional calcium channel antagonists. Beta receptor antagonists may be required after alpha receptor blockade has been instituted to reverse the cardiac effect of excessive catecholamines. Beta antagonists should not be used prior to establishing alpha receptor blockade, since unopposed beta receptor blockade could theoretically cause blood pressure elevation from increased vasoconstriction. Pheochromocytoma is sometimes treated with metirazine, uh, the alpha-methyl analog of tyrosine. This agent is a competitive inhibitor of tyrosine hydrolase, uh, the rate-limiting step in the synthesis of dopamine, norepinephrine, and epinephrine. So, metirazine is especially useful in symptomatic patients with inoperable and metastatic pheochromocytoma. Because it has access to the central nervous system, metirazine can cause extrapyramidal effects due to reduced dopamine levels. So the next disease is hypertensive emergencies, and the alpha adrenoceptor antagonist drugs have limited application in the management of hypertensive emergencies, but labetalol has been used in this setting. In theory, alpha adrenoceptor antagonists are most useful when increased blood pressure reflects excess circulating concentrations or alpha agonists, for example, pheochromocytoma, overdosage of sympathomimetic drugs, or clonidine withdrawal. However, other drugs are generally preferable since the considerable experience is necessary to use alpha adrenoceptor antagonist drug safety in these settings. Next disease is chronic hypertension. The Prazosin and doxazazine and uh, terazazine are most useful drugs in this setting, uh, and they are generally well tolerated, but they are not usually recommended as monotherapy for hypertension because other classes of antihypertensives are more effective. Uh, uh, The major adverse effects of uh, these drugs are orthostatic hypotension and uh, and other adverse effects are not uncommon. Non-selective alpha antagonists are not used in a primary systemic hypertension. Prazosin and related drugs may also be associated with dizziness. Orthostatic changes in blood pressure should be checked routinely in any patient being treated for hypertension. It is interesting that the use of alpha adrenoceptor antagonists such as prazosin has been found to be associated with either no changes in plasma lipids or increased concentrations of high-density lipoproteins, which could be a favorable alteration. The mechanism for this effect is not known. Alpha receptor blocking drugs do not seem to be effective in the treatment of peripheral vascular occlusive disease characterized by morphologic changes that limit flow in the vessels. Occasionally, individuals with Raynaud's phenomenon and other conditions involving excessive reversible vasospasm in the peripheral circulation do benefit from prazosin or phenoxybenzamide, although calcium channel blockers may be preferable for most patients. The next disease is most uh, uh, useful. So the benign prostatic hyperplasia is common in elderly men, and various surgical treatments are effective in relieving the urinary symptoms of benign prostatic hyperplasia. However, drug therapy is efficacious in many patients. The mechanism of action in improving urine flow involves partial reversal of smooth muscle contraction in the enlarged prostate and in the bladder base. It has been suggested that some alpha-1 receptor antagonists may have additional effects on cells in the prostate that help improve symptoms. Prazosin, doxazazine, and tazrazine are all efficacious in patients with benign prostatic hyperplasia. These drugs are particularly useful in patients who also have hypertension. Considerable interest has focused on which alpha-1 receptor subtype is most important for smooth muscle contraction in the prostate. Subtype selective alpha-1A receptor antagonists may have improved efficacy and safety in treating this disease. As indicates above, tamsulosin is also efficacious in benign prostatic hyperplasia and has relatively minor effects on blood pressure at a low dose. This drug may be preferred in patients who have experienced orthostatic hypertension with other alpha-1 receptor antagonists. So, and then the most important disease is erectile dysfunction. A combination of phentolamine with the non-specific smooth muscle relaxant papaverine when injected directly into the penis may cause erections in men with sexual dysfunction. Long-term administration may result in fibrotic reactions. Systemic absorption may lead to orthostatic hypotension. Priapies may require direct treatment with an alpha adrenoceptor agonist such as phenylephrine. Alternative therapies for erectile dysfunction include prostaglandins, sildenafil, and that is Viagra, and other cyclic guanosine monophosphate phosphodiesterase inhibitors. So I think that is all for today, and we will continue at the practice next week. Thank you very much for your attention, and see you next week.
See you.
Thank you. Goodbye.
Thank you, Sal. Goodbye.
Bye bye.